Okay, so this is part 2 of the tubular reabsorption slide-based lecture. So we're going to pick up where we left off. We're still in the loop of Henle. We're talking about transport in the loop of Henle. And just to sort of do a refresher, remember the loop of Henle has two sides, okay? And they are different, all right? When the descending limb of the loop of Henle has tubular flow, okay, so fluid is moving down the loop of Henle, there's no solute reabsorption, but water is reabsorbed. So it's permeable to water, but not solute, like sodium and potassium. But then as you come up the loop of Henle, right, the ascending limb, now it's permeable to solute because we have that sodium potassium chloride cotransporter that we just talked about at the end of the last video. So that channel is ever present, and it's reabsorbing lots of solute, and that process requires energy. But the cells here are impermeable to water, so there's tight junctions and there's no water reabsorption. So this is kind of cool, right? If you think about it, as the tubular fluid comes down the loop of Henle, it's becoming more concentrated as you come down, right? And then as you go back up, it's becoming more dilute, right? Because as we come down, we're sucking out water, but leaving behind the stuff like the solute. And then as we come up, we're taking out the solute, but leaving behind the water. And so what this does, we're concentrating urine on the way down, and we're diluting urine on the way back up. This is kind of cool, and this allows the kidney to create something called the medullary osmotic gradient, also known as the cortico-papillary osmotic gradient. Sorry about the different terms, but those are the different terms we see. So if we were to sample the interstitium of the kidney, look out at the cortex, the tonicity of the interstitium is about the same as plasma, so it's like 300 milliosms per liter. But look, as you go down the medulla, as you know, moving towards the center of the kidney, it becomes extraordinarily concentrated, all the way up to 1200 or 1400 milliosms per liter. Well, you know, how does that happen, and why does that happen? So it occurs because of two processes, essentially countercurrent multiplication, okay? Now what's happening, remember, this is just another diagram showing you how water is taken out of the descending limb, and then solute is taken out of the ascending limb, and water is left behind. So we concentrate urine on the way down, and we dilute urine on the way up. This segment here, it's also called the diluting segment. If you hear someone mention that, that's because solute is removed, but water is left behind. This flow here, the fact that you have a descending piece right next to the ascending piece, and they have different properties in each limb, that's called countercurrent property, all right? And countercurrent multiplication is the mechanism that's involved here. Now you may be wondering, well, how are you able to concentrate the interstitium? Because, you know, y'all are all really smart, and, you know, if I was looking at this, I would say, well, weird, we just dumped sodium and chloride into the interstitium, and then we just put water into the interstitium. Wouldn't those just cancel each other out? Like, equal amounts of water and sodium chloride, wouldn't that just make the interstitium isotonic to plasma? And I think that's a totally fair argument, but the fact that we can maintain the cortico-papillary osmotic gradient is because we have countercurrent exchange with the vasa recta. So remember, next to all the tubules, we have capillaries that are immediately next to everything to pick things up. So one cool thing that's happening is, of all the sodium chloride that's being reabsorbed in the ascending limb of the loop of Henle, there's vasa recta right here ready to take it away, okay? And so the vasa recta can take some of the sodium chloride and return it to the systemic circulation, okay? Remember, the thick ascending limb is responsible for reabsorption of 25% of the filtered sodium. This is how that's going to go back to systemic circulation and help maintain balance overall, okay? So imagine the vasa recta. Look, this is essentially efferent arteriole, and then breaking down into peritubular capillaries, vasa recta. It takes up lots of sodium and chloride right here. So now the vasa recta is really concentrated, right? So it's really concentrated. Oh, and guess what? As soon as it comes around towards the descending limb of the loop of Henle, right? The vasa recta is loaded with sodium and chloride. It's hypertonic temporarily. And so guess what? Now there's a driving force for it to reabsorb all of this water, right? The tubular fluid here is giving up lots of water. The vasa recta is taking up lots of water, okay? And so if the vasa recta is able to take up the salt here and take up the water here and immediately restore it to systemic circulation, that means it won't dissipate the interstitial tonicity, okay? Now, some of the sodium chloride is left behind, okay? So 50% of the sodium chloride that's reabsorbed remains in the interstitium. The other component of the interstitium is urea. So that tonicity, right, the reason it's able to get to 1200 is because we're pumping urea and some sodium chloride into the interstitium, but we maintain it by this countercurrent exchange with the vasa recta, okay? Now, what's the big picture? Like, why even do this? Why do we even care about maintaining a cortico-papillary osmotic gradient, right? Why don't we just keep the whole thing isotonic to plasma, which would be around 300? Well, the whole purpose for keeping this heavily concentrated really corresponds to another lecture that we're going to have on body fluid osmolality or tonicity. But basically, if the kidney needs to reabsorb water, right? Imagine if you're in somewhere where you don't have access to water, right? And you're at risk of dehydration, we need a really robust mechanism for holding on to water. And this is how the kidney does that. It maintains a very high osmotic gradient inside the interstitium. And then at a moment's notice, with a signal, and that signal is a hormone called ADH, antidiuretic hormone, or vasopressin. Again, there's an entire lecture and video series based on that, but I'm just trying to connect the two. In the presence of that hormone, you have to have a way to reabsorb water, okay? Now, that hormone will put water channels in the collecting duct, and when the water channels are present, water will now move from an area where it's very dilute in the tube, right? So very high water concentration, one way to think about it, to an area with very low water concentration but high solute concentration. Now water has a force to be reabsorbed, right? Because really the only way you could move water in tissues or across cells is by osmotic gradients. So the kidney has to set up high concentration of osms, has to make it hypertonic in the interstitium so that you can reabsorb lots of water at a moment's notice, okay? All right, so bear with me. You can establish a high cortico-papillary osmotic gradient thanks to all of these processes. Countercurrent multiplication happening with the descending and ascending loop of Henle, and then countercurrent exchange with the vasa recta. Now, these are different loops of Henle, okay? There's a short loop, a medium loop, and a long loop of Henle. These are from different animals, and so if you can imagine, this really long loop of Henle allows you to really, really concentrate the interstitium, which allows you to really concentrate your urine if you have to. So if you can imagine what kind of animal would have a really, really long loop of Henle in the kidney, well, it's the kangaroo rat. So this rat lives in a arid environment, not a lot of access to water. In their urine, they can concentrate their urine down to, it's almost like a paste-like substance. So imagine they can suck out all the water from the tubular filtrate, which eventually comes out to urine, and it's like a paste-like material, okay? What kind of animal do you think would evolve to have very short loops of Henle? Hint, this would be an animal that doesn't really have to concentrate their urine. This would be an animal that mainly lives in a very wet environment. So the beaver, as long as they live in and around water and they don't travel outside that area, they're fine. If you can imagine their urine, they're not able to concentrate urine very well. They probably make a lot of dilute urine and they don't have much capacity to concentrate it. So as long as they're like in and around water, they're probably fine. And humans are in the middle, right? So we're sort of in between. We have some capacity to concentrate our urine, but we're not as good as the kangaroo rat. And we have better capacity than beavers, and so that's why we can live away from rivers and streams and whatnot. Okay, so what's really happening, and this is really just a supplementary slide because I know some of you are going to want to know, like, no, wait, like how is this actually happening? This is actually how things are occurring and what is happening on the sort of a quantitative level as far as concentrations, but essentially, if you could see, is that when water is moving out of the descending limb, it's concentrating up the tubular fluid. And then when solute is actually pumped out of the ascending limb into the interstitium, right, it's diluting the segment as it ascends. And you can see how these two things impact one another and actually establish this cortico-papillary concentration gradient. So this is the countercurrent multiplier, and it only exists because you have the two limbs that are doing different things right next to one another. That's what countercurrent does. And so this is really just for your curiosity, as I'm sure you're curious about how this occurs. This is considered a really difficult concept, so if you're confused, that's okay. But I would just sort of maybe stare at this a few times and look at the numbers, and eventually it will make sense. But the reason this is able to exist and not just immediately dissipate is because you also have countercurrent exchange with the vasorecta, which are moving in this direction, the opposite direction. So the vasorecta are able to carry away water and salt so that you don't just dissipate the gradients immediately. Okay, now that we've left, or we're leaving the loop of Henle, I do want to revisit tubuloglomerular feedback. And I know this is also covered in a glomerular filtration lecture and series, and it's worth revisiting just because we're right here. So now we're leaving the loop of Henle and we're in the distal tubule. And so this is a really cool mechanism, basically to where the kidney sort of checks back on itself. So the nephron is sort of has this feedback mechanism. I like to think of it as the glomerulus sort of looking over its shoulder and saying, "Hey, like, how are we doing on sodium balance, and what do I need to do regarding the GFR?" And so this is what I want you to focus on right here. So the distal tubule comes right back up and is affixed right here to the afferent arteriole, right, feeding right into the glomerulus. And then there's these special cells called juxtaglomerular cells, so not right next to the glomerulus cells. So all these cells are in tight proximity, so they can communicate with one another. And this is really cool. And so if you could zoom in, so here's the tubular fluid on the left, here's the macula densa cells right here, and here's the juxtaglomerular cells right here, and as you can see, the afferent arteriole. So these are all the layers. So that sodium potassium chloride cotransporter that we just saw in the ascending loop of Henle, that's the transporter that's on the cells at the macula densa. The macula densa, I want you to think about it as simply a sodium sensor. It's sensing sodium chloride delivery to this segment. And essentially all it's doing, it's taking that information and communicating that to the juxtaglomerular cells. And what is the final receptor? It appears to be mediated by adenosine receptors. Okay, so macula densa sensing salt delivery, sodium and chloride delivery. Okay, the transporter is that sodium chloride potassium cotransporter that we just saw in the ascending loop of Henle, and it's mediating vasoconstriction and renin release at the afferent arteriole. Okay, so how does it do that? Well, here's what's happening. If the macula densa is getting large amounts of sodium chloride, okay, think about it, that will result in increased stimulation of those adenosine receptors. That will lead to constriction of the afferent arteriole. That will drop the GFR a little bit, and it will decrease the secretion of renin. Okay, renin is the hormone secreted by the juxtaglomerular cells. Remember, renin eventually initiates a cascade that results in sort of a vasopressor effect through angiotensin II. So the goal is to increase blood pressure, okay, and also to boost GFR by preferentially constricting the efferent arteriole. So with high sodium delivery, this will constrict the afferent arteriole a little bit, which will drop the GFR a little bit and decrease, so put the brakes on secretion of renin. And the way we think about this, remember from the GFR topics, this is part of auto-regulation of GFR. The purpose of this is that the body and the kidney wants to keep GFR completely constant despite whatever changes are happening, whatever drama is occurring. And the kidney does not want GFR to vary widely according to fluid or salt status. Okay, so the idea would be you should be allowed to have a very salty diet and high fluid intake and not have that dramatically change the GFR. This is how your body can put the brakes on GFR despite changes in salt status. So if there's lots of sodium arriving to the macula densa, that means that even after reabsorbing lots of sodium in the proximal tubule and the loop of Henle, there's still a lot left over. Okay, that is a signal to the macula densa. Hey, like there's enough salt in the body. We could be hyperfiltering at the glomerulus. Maybe we should put the brakes on the GFR right now. Oh, and we should put the brakes on renin because we don't need to be propping up blood pressure anymore. Okay, we don't need to be hyperfiltering, and so this is one way to protect against that. Again, this is part of auto-regulation of GFR. Now the opposite is true. What if there's a decreased sodium chloride delivery? Let's say that you've had low access to fluid, low access to salt. You're in a desert. You don't have access to good food. Okay, now you're starting to get volume depleted. You're going to heavily reabsorb salt and water in the proximal tubule, heavily reabsorb salt and water in the loop of Henle. Very little salt is making it to the macula densa. Okay. Now, this is a way for the macula densa to say, hey, I don't know, like we're really low on salt and water. Something's a problem. We may be volume depleted. We may be bleeding to death somewhere. We may be lost in the desert with no access to food. I don't know what's going on, but we still need to maintain a good GFR, and we may need help to prop up our blood pressure. So the signal will go to the juxtaglomerular cells. We need to dilate up the afferent arteriole to maintain a GFR despite perhaps a change in blood volume, perhaps a change in extracellular fluid volume. Oh, and we have these hormonal ways to prop up our blood pressure. Let's increase renin secretion. And so if you follow the cascade of renin, eventually you will increase angiotensin II, which has a vasopressor effect. It will also preferentially vasoconstrict efferent arteriole, which will help boost GFR even more. And eventually it will lead to secretion of aldosterone, which is a mineralocorticoid that will help sodium retention at the collecting duct. So all those things are things that will help prop up extracellular fluid volume and blood pressure in the setting of perceived volume depletion, okay? Which would be low sodium chloride delivery at the macula densa. So this is all about auto-regulation of GFR and maintenance of blood pressure. Okay, so moving right along, now we're going to finish up at the final segment. So we have two more segments of the nephron. There's the distal convoluted tubule, okay, right after the macula densa, you can see right here. So the distal convoluted tubule and then the collecting ducts. Here are the big points for these two segments. Number one, the reabsorption of like 8 to 10% of filtered sodium occurs in these two segments, okay. There is additional calcium and magnesium reabsorption, okay. The collecting ducts is the site of potassium secretion, okay? So we've been talking about absorption a whole lot. Now we're talking about secretion, which means, oh, we have too much of that stuff. Now we need to get rid of it to maintain balance, okay? This is where you get rid of potassium if you need to. It's also the site of acid secretion. So this is where we get rid of protons as those things build up. Also the site of water reabsorption, which I alluded to at the beginning, okay? So what's the transport in the distal convoluted tubule? We also call this the DCT for short. So at the distal convoluted tubule, there is a sodium chloride cotransporter, which is able to reabsorb sodium and chloride in an electroneutral fashion. So obviously if a positively charged ion and a negatively charged ion move together, we're not changing electrochemical gradients, so that's great. And then also this segment is impermeable to water, just like the ascending loop of Henle. So if we move solute out of the lumen but leave behind water, we're continuing to dilute the urine, okay? Another thing, as you move a little more distally, there is more calcium reabsorption, okay? And remember, we're in the distal convoluted tubule. there is more calcium reabsorption, and this one has some switch on it, and it's dependent on vitamin D and this hormone called parathyroid hormone. Okay, and as you can see on the back end, all of this is fueled by the sodium-potassium ATPase, and we believe there's like a sodium-calcium exchanger that helps facilitate the calcium gradient to keep it low enough so that calcium can move into the cell. And just real quick, while we're talking about the distal convoluted tubule, in terms of the tubular fluid osmolality, that segment is called the diluting segment. Remember, we're reabsorbing sodium chloride in the absence of water. We're leaving water behind. So if you were to sample that segment, we would see a tubular fluid osm about 100 to 150 milliosms per liter. So it's still quite dilute compared to the interstitium and normal plasma, which would be about 300. So I just want to give you numbers to keep in mind. So maybe it's about 100, 150, and we could even dilute it even more if we had to by reabsorbing solute and leaving water behind. Okay, but really the final balance of how we handle urinary concentration and dilution will occur in the collecting duct. And again, that's covered in a different lecture series. Okay, now let's move into the collecting ducts. So there's some important transport happening in the collecting ducts. There are two main classes of cells. Okay, the first cell is called the principal cell. It must be important because it sounds like it has an important name, right? So the principal cell does the following, right? It has a sodium channel called ENaC, epithelial sodium channel, right? So that's a good name. So what's happening here? Sodium is reabsorbed by this luminal sodium channel, okay? When sodium moves into the cell, you can imagine that's not electroneutral, right? When potassium charges move into the cell. So it makes sense if you said, well, I don't see a good reason for how that would reabsorb lots of sodium. Well, the only way this mechanism can continue to work is because there is also potassium secretion, okay? Or potassium excretion via this channel called ROMK. So ENaC will reabsorb sodium, but in exchange for potassium, because if you imagine sodium moves in by itself, okay, maybe the intracellular potential is slightly more positive compared to the lumen, which now is slightly negative as sodium moves in. And sodium would only move in thanks to gradients, right? Because the concentration of sodium inside the cell is very low thanks to sodium-potassium ATPase. Sodium concentrations will be higher in the tubular fluid, so sodium will want to move into cells. But as soon as this gradient's established, not much more sodium is going to want to move until we start pumping out potassium. So the way this really works is that the more sodium that makes it this far, whenever sodium goes in, a potassium comes out. That's really all you got to know, okay? So thanks to the sodium-potassium ATPase, it's pumping the cell full of potassium, which potassium is just ready to leak out of here. But when a sodium moves in, potassium will leak out. So every time sodium goes in, potassium leaks out. And this entire process is stimulated by that hormone aldosterone. So aldosterone is a hormone produced by the adrenal gland. And in the setting of aldosterone, essentially aldosterone will increase transcription of these proteins, and it will increase transcription and activation of the sodium-potassium ATPase. So these cells get more active, they get more energetic, and they're able to do more, net movement of these substances. Okay, so the main takeaway is that this is a site of sodium reabsorption and potassium secretion. So they both go together. Okay, now let's talk about the intercalated cell. There are actually two kinds of intercalated cell. There's the alpha intercalated cell and the beta intercalated cell. I'm showing you here the alpha intercalated cell. Essentially, the purpose of this cell is acid-base balance in the kidney. And so the intercalated cell, especially the alpha, which we're showing right here, is the site of acid secretion. So that's how I remember it. Alpha, A, acid, that's the job it does. Here's how it does it, okay? There's intracellular carbonic anhydrase, okay? So it will turn CO2 and water into carbonic acid, which will dissociate into a proton and bicarbonate, okay? Once those species are freely available in solution inside the cell, now we can separate the two. Okay, so the intercalated cell has a luminal hydrogen pump that uses ATP to pump hydrogen ion or protons into the lumen. Okay, so remember, we're at the collecting duct. We're like almost out of the kidney by this point, so urine is flowing in this direction. Whatever we pump right here is going to go into the toilet. So there's also a potassium proton exchanger. So, you know, we can get rid of protons if there's enough potassium passing by here and there's exchange for that. So remember, that would make a lot of sense as we start pumping potassium out of the principal cell. Then that means there's potassium that can be exchanged for protons. And so this makes a nice kind of a system for getting rid of protons, which we need to do. We generate protons every day, and we're going to talk about that more in the acid-base lecture, but part of being alive means we have to generate protons, and so this is our way of getting rid of those generated protons, and this is how the kidney keeps us in good acid-base balance. Okay, so purpose of intercalated cell, use energy, pump out H+ hydrogen ion, which is acid. Now, remember, we generated a bicarbonate, so the bicarbonate is going to get returned to the circulation, okay? And so peritubular capillary is on this side, and in exchange for chloride, right, there's a bicarbonate chloride exchanger. The bicarbonate will get pumped into systemic circulation, and the peritubular capillary will take it back out, okay? Now, this is the alpha intercalated cell. The beta intercalated cell is essentially a mirror image of this. Right, the intracellular machinery is the same, except for the beta intercalated cell, we'd be pumping the proton into the peritubular capillary to keep it, and we'd be transporting bicarbonate into the urinary space to pee it out. So the big picture is the following. We need the alpha intercalated cell to deal with the production of daily acid. Okay, so generating acid every day just from being alive. We have to pump out protons every day to be in balance. Okay, in the rare circumstances where we have essentially a metabolic alkalosis where we've generated too much bicarbonate, we have the beta intercalated cell that will allow us to dump bicarbonate into the urinary space and bring the protons into the peritubular capillary to bring acid, base, and pH back into balance. Okay. Now, the other big picture is that, you know, what's the ratio of principal cells to intercalated cells? It's probably 65% principal cells, 35% intercalated cells. So again, principal cells seem to dominate the landscape of the collecting duct. Again, the fine-tuning of the tubular fluid occurs here in terms of reabsorbing sodium, but here it's in exchange for potassium. Okay, this is key. It's the site of potassium secretion, and the intercalated cells are the site of proton secretion for acid-base balance. Now, finally, you know, this is just for fun, but really, you know, why does this stuff matter? Because I know we're talking a lot about transporters and ions and ATP, and it can be a little overwhelming. You know, this stuff really does matter in terms of how we treat patients, because we got to know this stuff because a lot of our therapies are going to block or augment all the stuff we just talked about. So when we treat patients with hypertension, for hypertension, we are changing all of these things. Okay, so ACE inhibitors and angiotensin receptor blockers, these are medicines that will augment glomerular filtration. And because angiotensin 2 does stimulate proximal sodium reabsorption, we impact the ability of the proximal tubule to reabsorb sodium. Okay, so these are ways we can improve blood pressure. All right. Again, in the distal convoluted tubule, remember there's that sodium chloride cotransporter. We can block that with thiazide diuretic. So the most popular one is HCTZ, hydrochlorothiazide. There's another one called chlorthalidone. So this is first-line therapy for the treatment of hypertension. Just blocking that transporter, we're reducing the reabsorption of sodium chloride, and then people pee out more salt. Hey, their blood pressure gets better. There you go. It's as simple as that. So one of the most common and you know, well-established therapies for hypertension are thiazide diuretics, and you're going to prescribe them sometime in your life. Also for heart failure, patients who, if their heart's not working for whatever reason, signals go to the kidney to reabsorb salt and water like crazy, because that's how the body responds to things. When there's low perfusion, the kidney's going to reabsorb salt and water, thinking that that's the solution, but it's actually not. We also use ACE inhibitors and angiotensin receptor blockers to downregulate those maladaptive responses. We use loop diuretics, and so a loop diuretic is a medicine that blocks reabsorption of solute at that sodium potassium chloride cotransporter at the ascending loop of Henle. So loop diuretics include furosemide, torsemide, and bumetanide. These are amazing medicines. We use them all the time. You got to know it. It's the thing you have to have in your tool belt to know how to use to take care of patients. So incredibly important. Also, remember how I said aldosterone stimulates sodium reabsorption and potassium secretion at the principal cell? Well, we have aldosterone receptor antagonists, so we can block that. And these are a few medicines, like one's called spironolactone and another one's called eplerenone. So we have medicines we can use to block those mechanisms and treat hypertension, treat sodium retention, treat heart failure. All this stuff has been shown to really improve quality of life and outcomes, especially for heart failure specifically. ACE inhibitors, ARBs, and the aldosterone receptor antagonists have been shown to improve like hard clinical outcomes. The loop diuretics clearly improve functioning and fluid balance as well. Now, another cool thing is that we do have a new treatment for type 2 diabetes that blocks proximal reabsorption of glucose and sodium. They're called the sodium glucose cotransporter inhibitors, SGLT2 inhibitors, and they have just taken off lately as I hate to say sort of magic pills, silver bullets. But in addition to improving glycemic control, like they improve diabetes, it also improves blood pressure. People have lost weight. It's improved heart failure outcomes. It's improved, the rate of hospitalizations in heart failure. It's also slowed the progression of chronic kidney disease and helped people with kidney problems. So it's kind of had so many benefits. And this is something that just came out, and you're probably going to be prescribing this more frequently in the future. So understanding how all of these things work is incredibly important, and I think tubular transport is central to so many medical diseases, and the better you understand it, the better you're going to be able to care for your patients.